So we're going to try something new today. We're going to show you multiple examples of one diagnosis. And the diagnosis I'm going to show you is NSIP, nonspecific interstitial pneumonitis. And so here's a nice example. This is actually a combination of, it looks like nonspecific interstitial pneumonitis as well as organized pneumonia. So at the lung bases, we see a lot of ground glass opacity with some perilobular areas of consolidation. For example, here in the lingula, see this perilobular consolidation. I think if you look carefully, you can also note that it's present within the right middle lobe as well. But you do have to squint here. You have to really inspect carefully, looking for these perilobular areas of consolidation. And we know perilobular consolidation, especially at the lung bases, is highly associated with organized pneumonia in the chronic setting. So this is actually a combination of the organized pneumonia with the ground glass opacity, which likely represents non-specific interstitial pneumonitis. Here's a nice example of sort of a targetoid appearance of organized pneumonia here in the right lower lobe. So why does it do this? Not quite sure why it likes to do this, but organized pneumonia oftentimes will give you this appearance, almost like a reverse halo configuration. So this combination of consolidation and ground glass opacity at the lung bases, clearly in the subacute to chronic setting, is highly associated with myositis. And indeed, this patient ended up having myositis. And one of the things about this combination of NSIP and organized pneumonia is that we know that organized pneumonia is exquisitely sensitive to corticosteroids. And so that tends to clear very quickly. And so that's going to be the consolidation. And so 1 year later, all that consolidation has melted away, and we're just left with this mild underlying ground glass opacity, which certainly looks good for NSIP. There is also relative subpleural sparing. Again, this is real life. You kind of have to squint, but it certainly looks like the subpleural portion of lungs are at least relatively spared. So this is a typical evolution of disease in patients with myositis-related NSIP and organized pneumonia, evolving into more of an NSIP pattern. Another example of NSIP here, nonspecific interstitial pneumonitis. This patient had undifferentiated connective tissue disease, what we would now call interstitial pneumonia with autoimmune features, though that term is really a research terminology at this point. Well, bottom line, this is a patient who had a flavor of connective tissue disease clinically, but didn't meet strict criteria for any specific connective tissue disease. And so this ILD in here, this pulmonary fibrosis, is thought to be related to an underlying connective tissue disease. And so again, we see basal predominant reticulation, a little bit of superimposed ground glass, and certainly there's exuberant traction bronchiectasis, which we commonly see in patients with NSIP. Also note that there's relative subpleural sparing. So if we look here, let's look in the right middle lobe. So this patient's obviously already been biopsied. This is biopsy proven. We see relative subpleural sparing. So it looks like the most severe disease is more centrally in the lung. And again, here in the right lower lobe, again, relative subpleural sparing. Central lung more involved, more peripheral portion of lung less severely involved. And we see similar findings in the left lung. There is some peripheral involvement, but clearly more central than peripheral. And very often, what's helpful is to look at reformations. And so if we look at the coronal reformation here, we'll see that indeed it does look like there's relative subpleural sparing. So right here is this essentially this rind of outer lung, which does not look affected or is certainly not as severely affected. And the same thing on the other side in the left lung, perhaps not as evident as in the right lung. But again, if you look carefully, it looks like the central portion lungs are more severely affected. Also, a nice example here of what we call the straight edge sign. So what do we mean by straight edge sign? It means with a straight line, you can demarcate where normal and abnormal lung is at the lung bases. And so we have published data that shows definitively, I think, that the straight edge sign is strongly associated with connective tissue disease. And so this is regardless of the underlying imaging pattern itself, whether it's actual UIP or NSIP, if it has that straight edge sign, there is a strong association with connective tissue disease. And then also if you're trying to figure out whether you have a pattern of NSIP versus UIP, if you have the straight edge sign, it's strongly suggestive of NSIP rather than UIP in terms of histological pattern. So both in terms of clinical diagnosis and in terms of histology, number one, it points to connective tissue disease clinically, and it points to NSIP histopathology when we're talking about tissue sampling. So another example of NSIP here. Again, we see a little bit of ground glass opacity, reticulation, some traction bronchiectasis. Clearly basal predominant. Another example of subpleural sparing. Note the exuberant traction bronchiectasis here. This is pretty typical of nonspecific interstitial pneumonitis. I don't think there's much data out there that demonstrates this, though, that's definitively shown it. Though I think that most people would agree that this is a typical finding of NSIP on HRCT. Patient also has a little bit of a lung herniation here, presumably due to some sort of defect within the chest wall and possibly the pleural space there. All right, but this is a typical example of NSIP with relative subpleural sparing. So again, you're going to see subpleural sparing or relative subpleural sparing in a minority of cases. So anywhere from 30 to 40%, depending on who you are reading. At University of Chicago, our number is somewhere in more the 25 to maybe 23% range. And so why is that? It's I suspect it's because a lot of the easy patients, so these patients with classic subpleural sparing, have been already diagnosed in the community. So once they're referred to our center, we get more of the hard or difficult patterns. So I think more and more people are realizing that when you get this subpleural sparing within the lung parenchyma in patients with interstitial lung disease, NSIP is very high on the differential diagnosis. Another example here with a straight edge sign here. Again, supporting the diagnosis of NSIP in this patient with connective tissue disease. So I did want to show you an example of nonspecific interstitial pneumonitis without subpleural sparing. So again, basal predominant, ground glass opacity, and reticulation with some traction bronchiectasis. But this is really more peripheral lung preponderant. And actually, in the majority of cases of NSIP on imaging, you're going to have it be peripheral or diffuse in the axial plane. But peripheral is going to be the predominant pattern there. Well, again, when you see subpleural sparing, though, it is highly suggestive of nonspecific interstitial pneumonitis. So here's another patient with, this looks more like an NSIP pattern, but a little more fibrotic. We're already seeing these cystic changes within the central portion of lungs, but there looks to be at least relative subpleural sparing. There's some peripheral involvement as well, but this looks to be more parabronchovascular than anything else. Ground glass opacity, reticulation, cystic changes, probably representing traction bronchiectasis and bronchiectasis. Not much consolidation, just a smidge. There are some perilobular opacities, for example, here in the left lower lobe, which does make you think about organizing pneumonia. And so I think what's very helpful is that we see how this evolves. So over the course of about 3 years, this is how the lungs evolved. We see all those areas of interstitial lung disease, the reticulation, have now evolved into a almost completely cystic abnormality. And so we wouldn't really call these areas centrally subpleural honeycombing. They really have to be starting the subpleural, most peripheral portion of the lung for us to invoke subpleural honeycombing. But there is honeycombing here. But I will tell you that in patients with connective tissue disease, very often they will have this pulmonary fibrotic pattern where almost all their fibrosis is cystic like this. Sure, there's a little bit of reticulation in left upper lobe, a little bit of smidge of ground glass opacity, but by far the vast majority of abnormality here is cystic changes. So let me just show you where that emanated from. So remember, it emanated from this pattern here. So we had much more ground glass opacity, a little bit of perilobular opacities, some reticulation, not as much cystic abnormality. So this evolved into that predominantly cystic change, which again is often seen in patients with connective tissue disease. And so this patient ended up having an overlap syndrome, or previously someone would call it an overlap syndrome. And so I think most people would now call this IPAF, so interstitial pneumonia with autoimmune features. Some people call this so-called undifferentiated connective tissue disease. So this patient had underlying history of systemic sclerosis. And so very interesting imaging pattern, a lot of cysts, some reticulation, some traction bronchiectasis as well. So we see some of these airways which are going into these areas and dilating up, for example, right in here. So I think we would call that traction bronchiectasis. And some ground glass opacity. There's hazy ground glass opacity within the lungs. I think that by definition, we would say there is some subpleural honeycombing. For example, in the left lower lobe, we see this subpleural cystic abnormality. But again, there's so many of these clustered cysts. You do think about connective tissue disease. Also, the fact that there is relative subpleural sparing here makes you think about connective tissue disease on top of the ground glass opacity. This patient does have systemic sclerosis. Now, there was a paper published in Radiology that talked about Dendroform pulmonary ossification or Dendriform pulmonary ossification. And I'll tell you, there is a lot of pulmonary ossification in this patient. So all these little calcified lesions, you might be tempted to just call them granulomas, but there's just way too many of them. There's way too many. And these calcified or ossified nodules, they're only occurring where the patient has interstitial lung disease. So that makes no sense whatsoever to just attribute this to granulomatous lung disease. So this is pulmonary ossification, and pulmonary ossification can occur in the setting of pulmonary fibrosis. And that paper in Radiology, which I think was well done, it talked about pulmonary ossification being more common in patients with idiopathic pulmonary fibrosis and systemic sclerosis. And I'll tell you, that's actually, I don't think that's true. We just published a paper that showed that in patients with systemic sclerosis versus patients with idiopathic pulmonary fibrosis, the rate of pulmonary ossification superposed on interstitial lung disease was nearly the same, a relatively high rate as well. But that this was statistically different from patients with hypersensitivity pneumonitis. So patients with hypersensitivity pneumonitis, they tend not to develop this pulmonary ossification for one reason or another. There is some anecdotal evidence that suggests that these areas of pulmonary ossification are related to chronic recurrent aspiration. And we know that chronic recurrent aspiration can be seen in patients with idiopathic pulmonary fibrosis, or at least associated with idiopathic pulmonary fibrosis. And some people suspect in patients with systemic sclerosis as well, given the fact that they usually have, or very often have, esophageal dysmotility, which certainly puts them at risk for microaspiration. So for those of you guys who are interested, I'll put a link to various papers I talk about at the end of this talk. And here's another example of this combined NSIP with organized pneumonia patterns. So basal predominant ground glass opacity, reticulation, traction bronchiectasis, and a lot of superimposed parabronchovascular consolidation. So in a patient with this initial imaging pattern, oftentimes presenting subacutely, you're really thinking about myositis or its cousin, the antisynthetase syndrome. Indeed, this patient did have myositis. Over time, again, I think in addition to the initial CT pattern, looking at the evolution of disease is important. So this patient, let's show you a CT from 5 years later. In this patient, the consolidation is markedly improved. Now there's residual ground glass opacity and reticulation within the lung parenchyma, again, basal predominant. And there is increased coarsening of the pulmonary findings. And some might even question some early subpleural honeycombing within the lung periphery. For example, here in the right middle lobe. So I will say that some of this is probably just reticulation, but the subpleural stuff, the most peripheral stuff, that does look like it could be cystic. And so this could be very early honeycombing. And indeed, if we do look at the CT performed 4 years after that, we see that, again, those areas of peripheral lung reticulation that mimic honeycombing now look like pretty obvious subpleural honeycombing. Again, note the exuberant traction bronchiectasis that we commonly see in patients with NSIP. So overall, what is this pattern doing? So initially, it was an NSIP organized pneumonia pattern, which then evolved into more of a fibrotic NSIP pattern. And now it's sort of in flux. It's evolving from NSIP into UIP. And so UIP, as you guys probably know, it really represents end-stage pulmonary fibrosis. So there are many different conditions which can evolve into a UIP pattern. And so this looks like it's starting to move in that direction. Though, again, note this beautiful traction bronchiectasis that implies that this emanated from a NSIP pattern. if you had perhaps just this single CT to examine and evaluate.